Ghana as a country has taken 15 years trying to achieve the Millennium Development Goals, or MDGs 4 and 5, which aim at reducing child mortality and improving maternal health respectively by the set target year 2015. In just 2 years, some of the poorest districts in northern Ghana with very high infant, child and maternal mortality have achieved more than the set target of the MDGs. They have recorded zero maternal and infant mortality. This was made possible under a comprehensive health program with special focus on community health worker implemented by SADA Millennium Villages projects.
We have trained the community health workers who are people resident in the respective communities to be able to move from household to household to deliver the various interventions to improve their health status.
But bisi be walking there, one of gamma day, one of going into the Todita Nave, Sadaka boy, I walk God of fire. Bottom, war laughing cover. Dome, Vano on the tower me. Vano and Zayava, Huna Menom Zayava. Beside our brown, Broken Kawa, and war go broma. And didn't so lucky Kawa. And I got an user daughter. I may fever Miss Rock and Cow. Gano Musida Fire. I'm a Nantabura. To a Ditanave. I thought will go on with that. So, walk on a watch and let walk free. I'm a Sadaka Baby, one over free can call. I'm a woman of good outside on a go or laughing no, or tired no, or what I you know. More never met.
SADA Millennium Villages Project, or SADA-MVP, is the result of a collaboration between the Savannah Accelerated Development Authority, Millennium Promise, the Earth Institute at Columbia University, and the United Kingdom's Department for International Development. The overall goal of SADA-MVP is to assist a specific population in the rural northern Savannah belt of Ghana in achieving the Millennium Development Goals. SADA-MVP is being implemented in 35 selected communities in the Bulsa South district of the Upper East region and West Mampusi and Mampugu-Mwaduri districts in the northern region.
Thank you very, very much.
Before commencement of SADA-MVP in its operational communities in 2012, one sector that was bedeviled with very huge challenges is the health sector. Though there have been interventions by successive governments and other stakeholders, the beneficiary communities had to travel long distances to access health care, and maternal, infant and child mortality rates were very high.
Mampugu-Mwaduri is one of the newly created districts in northern Ghana. We started operation as a district in the year 2012. Now, when we came, we started operations. Basically, there was absolutely nothing in terms of health in the district. We have just 2 health facilities. How to get human resource, which is a backbone to health service delivery, was critical. So, getting people posted to the place is so deprived that people refuse postings to the place.
A pregnant woman or a child in a critical condition was brought to either Bulsa North, that's the Sandoma District Hospital, in a bad state, and the maternal deaths there were quite rampant. Similarly, that applies to the West Mampusi. They had to go on a bicycle or a motorbike to Walwale, taking not less than 2 hours to get to Walwale, that's the District Hospital of West Mampusi.
But this story is now history, thanks to the Community Health Worker, or CHW initiative, a subsector under a comprehensive health model of SADA-MVP.
We know that in Ghana, the human resource for health is quite a problem. So, and they cannot be at each community at any time. And therefore, especially in deprived communities where MVP works, it is important that each household have access to health service delivery timely and appropriately. The core objectives of the health program are aligned to the Millennium Development goals that we concluded in 2015 September. And basically, for the health sector, the goal 4, 5, and 6 are basically the core areas that we intend to address, and that is to reduce by 2 times child mortality, improve maternal health, combat HIV and AIDS, TB, malaria, and other communicable diseases. So the project's core interventions in addressing these objectives include building or strengthening the health system, and also improving geographic and financial access to health service delivery. And also, we also have to working to improve the health-seeking behavior of the populace. And last but not the least, we also work with relevant stakeholders in health service delivery in the communities and clusters that we work in.
The initiatives focuses on participatory community decision-making and uses improved science-based technologies and techniques.
The commonest bacteria is what we call Neisseria meningitis. That's the organism. And it causes...
They introduced the community health workers system as part of strategies to augment the few staff that we have in the SADA-MVP cluster area. So some people were selected within the cluster area, people who basically can read and write and be able to handle a phone, to be able to transmit information to SADA-MVP. So they were trained basically to help in the communities, and they were supposed to take care of some of the diseases that are occurring in the community and which can be managed at the local level.
In each community, we ask for 3 to 5 volunteers. So when they gave us this, we screened them and came out with just the 2 of them. But one is actually the lead person who is active. The second one is a backup. In the event that something happens, we can easily give a refresher training on that. Currently, we have 55 community health workers serving in 35 communities in the MVP cluster. And this includes the Busa South District in Upper East Region, Mampuru, Mogduri, and West Mamprusi in Northern Region, part of the cluster.
We are having a 2-day training on maternal and child health with the community health workers. We are taking them through how to recognize pregnant women, counsel them, follow them until time that they are due for delivery. Then they take them through birth plan until they deliver safely in the facility.
They were trained how to identify the key signs and symptoms of malaria and give appropriate treatment. They were also trained how to manage pneumonia and give some antibiotics.
A typical day of the community health worker begins with a visit to a selected households. Upon arrival, the health worker exchanges pleasantries and seeks permission to talk to the members. They find out about the health and nutritional status of the household and advise them accordingly.
Today's coming is on newborn visit. First of all, I have to wash my hands with soap. After that, I then let them bring the child out and I examine him. The danger signs I look out for, one is the sunken fontanelle or baldy fontanelle, discharge on the eyes, yellowish of the eyes, redness of the skin, or redness around the umbilical. So when I find any of the danger signs, I have to refer her with the baby to the clinic. And if none of the danger signs are in, I have to advise her how to cater for the child, to keep the child clean, to keep him warm by putting the baby on heavy clothes, putting socks and hats, and also how to bath the child, and also how to breastfeed exclusively.
Mama Puma uchana songa mapom. Blessma Papa down to eating sheep. Hale ni ito ansa. Oichana advisor ma don't to many sheep. Hope Papa down at the sheep them but to eat. Don't to eat doni sheep. Hale can down Santa Pai. Na umpang mga no hospital. Guaraza and they are a team. Kabacha Karama Aza. Hale can down Santa Pai. Mwando awa. Unanchana advice ma. For us, I don't to a marriage. The Bessomo and Chaka be my big year near she sick, Dumbuto. The yellow money she sick, a lego bear that the part on the sick, and promo socks, and Peroso Pelaga, the chicken tipsery, and the dear de massa. Didn't do tula, can you look on Pam dear nation can be some channel, can be man near Alafia, and the Chaka worry Joe.
In terms of children under 5, we have close to 3,600 children who are below 5 years that the community health workers are attending to. But the general population in the cluster per the 2010 census was estimated at 30,000 thereabout. Yeah.
Since I've started this work for 4 years now, I haven't seen any pregnant woman losing her life. So that means we are doing well, and they are doing well, because whenever we advise them, they listen to our advice, they go by our rules, and now they are all safe. And I'm sure this one, even if we've even stopped this work, or if this work program come to an end, I don't think they will go back to their previous method of delivering or delivering at home.
The community health workers are being supervised by trained community health nurses or officers. Now, these are Ghana Health Service staff, but because of the program, we have specifically trained them to be able to provide supervision and monitoring.
When we go for supervision, we use this phone. Basically, every information we need from the CHIU or the community members, they are on this phone. In case I want to do spot check, the spot check, I won't tell the CHIU that I am coming to the community. I will just enter the community without his or her knowledge. Then I will enter any house, and I'll begin to interview any house member I meet. What the CHIU has been doing on the field. It's a process. Everything has been arranged on the phone. So if I go to spot check, any CHIU I want to interview, everything is on my phone. So I go interview the mother or anybody at the household. They will give me all the feedback. Then I also send the information. At the end, it will tell me to score the CHIU. Then, upon what the woman has said, the description, I will use that description and now score the CHIU. Then we have the observational visit. The observational visit, I will schedule a date with the CHIU. Then we'll go out. When we go, I will tell the CHIU, I want us to visit this particular house or this house. So when we enter, the CHIU will be doing everything. Then I will be there with my phone, marking the CHIU. Where the CHIU did not do well, I will correct the CHIU. Then the CHIU will continue. Every step is step by step. They are all arranged here. So that is basically what we do when we go for CHIU supervision. Then again, we have another one at the health center. We call it CHIU box. That is where their drugs are stored. So if a CHIU should come to me that I've run out of drugs, I will take we gave them some forms. Anytime they go out or anytime they issue drugs, they will put it there. So I will collect that form, check through what the CHIU have given to compare to the last time the drugs I gave. If really the drugs are there or it's finished. Then if it's finished, I will give out again. Then I will indicate on top what I have issued out. Then if the CHIU come, what the CHIU have also given, I subtract it. Then I will get the ending balance for the CHIU. That is basically what we do.
The implementation of SADA-MVP projects and the community health worker approach in this case has not been without challenges right from inception till the last year of its implementation.
They use a phone called ComCare that has been configured, and this has to do with internet connection. So sometimes when the service is not good, the community health worker is confronted with he's not able to transmit the data as timely as we require. So sometimes we have to move to the field and then probably use a router or set up a different system that will allow the data to be synchronized, and then we can have it. Then in terms of supervision, I wouldn't call it a challenge as such, because we have the supervisors who are going to have service, except that sometimes their own workload probably may not allow them to to give the best of time that they would have wished. Nonetheless, they are doing their best, because when they have to visit, we have provided them with motorbikes. So when they have to visit a community health worker, they have to strategize, ensuring that their work is not affected, as well as they're going to provide the CW is also not affected.
There is no doubt the community health worker approach under the health sector model of SADA-MVP has been a blessing to these communities.
Previously, they used to cross the river and go all the way to Pasempe or to Sandema to access health. But since they built the facility, the pressure was too much on the facility until the CHU program came into existence, where they have to go through the community to identify children that are sick and pregnant women and give them a first aid treatment. If those that needs referral, they will refer to the facility. So as they are doing that, the OPD attendance have been reduced, because most of the cases that would have come here, they would have identified them and given them first aid treatment there, so they will be recovered.
Akabura madinda wambu ningawe adinda wo ko anadwa ko manganye so ko tare dwa kanko be wanye sumanso wa tare we annuko so wagawo fofo kano omanga bokata banka.
The community health workers who have acquired these skills over the years, we are quite concerned. What happens if the project ends in December? We think that with the government policy trying to roll out the 1 million community health worker program, it's an advantage for us in terms of sustainability. We think that our staff, that is the community health workers, can take advantage of this opportunity and then apply. And once they are recruited, they will continue to do the good work, because we cannot imagine the population that the community health workers are serving. Because it's not easy to get a Ghana health service moving from household to household, knowing the health condition of a child almost 24/7. It's highly almost impossible, not because they cannot do it, but because the resources are not there. Okay, so if the 1 million community health worker program comes, the community worry about MVP project come to an end, and what happens to their pregnant women, what happens to their children will not be a problem.
As Ghana struggled for 15 years to reduce by 2/3 child mortality and by 3/4 maternal mortality ratio, the SADA-MVP project communities achieved more than that in just 2 years after the project implementation. The operational communities are yet to record a single infant, child or maternal mortality as the project comes to an end in 2016, thanks to SADA-MVP's community health worker approach.
As this program is ending in December 2016, we are appealing for the government to come in to support our mothers to have this safe delivery in the health facilities. Why am I saying this? Because since this program started, none of my pregnant women lost their life. If government can sustain this and to implement it in other communities to also have safe delivery, it will help the whole country.
Manala,